Welcome back, everyone. I'm Sarah Iman, ISOR's President and CEO, and I'm thrilled to be spending the next couple of minutes with you as we talk about the policy implications of the deliberation and the votes that we just had with our CPAC. Before we dive in, a correction for the record due to a technical glitch. There was a vote incorrectly in the last vote for value. And so what we will be reporting is that 5 high value, 8 intermediate, 0 low value for the comparative value of COVID vaccines. So just wanted the audience to know that. That'll be reflected in our final documents. As I touched on today's introduction to the meeting, this public meeting of ICER and CPAC has been both different and the same as past public meetings because we've talked about the evidence. What does it tell us? What doesn't it tell us? We've talked about the value. Now, the prices picked by manufacturers, scaled to the benefits patients are receiving. In those regards, this has been a typical ICER CPAC meeting, as we've been doing for 20 years. But we recognize that making policies about vaccination recommendations, which is the purview of clinical societies, public health agencies, and payers, involves more than just a discussion of evidence and value. It involves considerations of population health, societal goals, messaging, clarity. Our roundtable today will talk about what we know about the evidence, about the value of COVID-19 vaccines, as we believe these are vital components of any subsequent recommendations. It's our hope that those with the power to make decisions about price, access, and coverage will find useful information from this discussion as they prepare to make recommendations. But I also want to note that both Gallup and the Edelman Trust Barometer have recently shown that trust in government, media, organized religion, higher education, and science is at or near record lows. A public meeting where we talk about what the evidence does and does not tell us about the COVID-19 vaccines is how you start to rebuild that trust. Thank you to this esteemed policy roundtable for being with us today. As we go to the next slide, so we can have each of our policy roundtable members introduce themselves and update any of their potential influences on judgment. I do want to mention that the manufacturers of the vaccines were invited to participate today, but chose not to. And I want to remind everyone listening in that we are only going to rebuild trust in this system, get to an affordable, equitable healthcare system when we all show up. And I believe they have an obligation to do so, to be part of a conversation about comparative effectiveness and value. And coverage mandates, as much as they do or do not exist right now, make that obligation even greater. So it's too bad that they chose not to participate. Kate Berry, thank you for being here. Why don't you introduce yourself and say hello?
Thank you, Sarah. Thanks for having me. Kate Berry. I'm with AHIP, the health insurance plans that we represent the vast majority of health plans. I think, Sarah's been talking 20 years, ICER, right? I think we've been a member for all 20 years, perhaps. So we really do value ICER's role. I have the privilege of working with the chief medical officers of the health plans for the most part. So also working on vaccines and other preventive services. So very excited to be a part of the conversation. No conflicts to disclose. Thank you.
Thank you. Thanks, Kate. I really appreciate you being here. Omar.
Thank you, Sarah, and good afternoon, everyone. It's been a pleasure being with you all this morning. This is my first time that I'm participating in an ICER public meeting, so this is fantastic, Sarah. And I have no additional disclosures. I do want to just mention again and reiterate that at the National Health Council, serve as a Chief Programs and Research Officer, and we are a patient-centered advocacy organization where members of industry are also core of our members. So I want to make sure that that's up and centered. And our role is primarily to lead our patient engagement, patient-centered approaches, ensuring that the voice of the patients is at the most center of all discussions, including this one. So I really just appreciate this invitation and look forward to our conversation and also just learning from the rest of our colleagues and how best we could provide these policy recommendations as we are navigating a very different and interesting landscape currently in the US.
I might start a little bit of a like a word game. How many ways are we going to describe this moment in vaccine policy? And interesting is one. So that good, you get a point. Omar, thank you for being here. And it won't be your last. So thank you for taking the time. Albert, say hello.
Hello. Um, I'm Albert Huang again. I'm a general internist, but I've been in practice for so long that most of my patients are octogenarians and nonagenarians. So I'm all kind of a backdoor a geriatrician. I'm a professor of medicine and public health sciences at University of Chicago. I study medical decision making, so I think a lot about how we make complicated decisions when there's very little information. I have no conflicts to disclose.
Thank you so much for being here. That perspective is so important. Kimberly, and let me know if Kim's okay. Not hearing Kimberly. I'm
How's that,
seeing
Sarah? Is that
Kimberly.
better?
There it is. Now I can hear you. Hello, welcome.
Perfect. So Kim is fine. My mother would prefer Kimberly, but you know how that goes.
Yeah.
Kimberly Leonard, though. I am a director at the New York State Department of Health, Office of Health Insurance Programs. I oversee the Medicaid pharmacy program, drug policy and rebate management, and actually also the elderly pharmaceutical insurance program. I'm a licensed pharmacist, and I've been with the Department of Health and several other state agencies for the last 20 plus years. So I'm a first-time joiner to this team, and I'm excited to be here. So thank you, Sarah, for having me.
Absolutely. Really appreciate you being here. I think the public payer perspective, the Medicaid perspective is going to be an important part of what we talk about today. So thank you. Lee.
Hello, everyone. Good afternoon. My name is Lee Purvis, and I'm the Prescription Drug Policy Principal at AARP, which is a nonprofit that works on behalf of Americans age 50 plus, where I help lead our work on prescription drug issues. AARP does receive royalties from third-party providers of our member benefits programs, which includes United Healthcare. However, those relationships do not influence AARP's policy and advocacy positions.
Lee, thank you. And Jason.
Hey everyone, Jason Schwartz again, Yale School of Public Health, Health Policy and Management Department. I study how evidence gets used in policy making and regulation, particularly around pharmaceuticals and even more so around vaccines and vaccination programs. So that's the focus of my work. In addition to research in that area, I've done a fair bit of policy advising both during COVID and during these turbulent times. Sarah, I'll add to your euphemism checklist here during these very turbulent times for vaccine policy. For state governments and other groups that are trying to navigate it, and no conflicts.
Thank you, Jason. Appreciate the addition to the list of the words we will use today. So as we dive into this conversation, a few things we'll make sure we're emphasizing throughout. One of the big goals I have for even why we picked this topic 8 months ago is I do truly believe in my bones that public deliberation is a way you rebuild trust. And we know that that is one of the things we need to do if we want to support a public health infrastructure around vaccination and other public health initiatives. We're going to mention a few times that we are not making recommendations about who should and should not be getting vaccinated, but we are going to talk about what the evidence tells us, where the evidence is lacking, where we might want more evidence, and give some advice to those who will have that important task in front of them in the next couple of weeks and months. And that future research needs. This ends up being one of the most important parts of a policy roundtable, because if you think back to my opening slides, this is an ecosystem where we are continually evaluating what we know, and that evolves over time, and that we want all of the different actors to be part of a commitment to developing new evidence where we need new evidence. But we like to start by thinking about and talking about health equity, which is where we're going to start today. And so we talked about this a bit in some of the votes and some of the conversation. We talked about confusion and distrust almost as an equity issue, right? Who is that? Who's being targeted with misinformation? Where is there distrust that we need to rebuild? For me, the uninsured are a population that we don't talk about quite as much because for a while we've been having really high rates of insurance, but that is changing this year due to turbulent and interesting times. And so we want to make sure that we're thinking about recommendations and approaches that don't leave them out. Representation in clinical trials always comes up when we talk about health equity, and of course, the social and economic drivers of vaccine access, race, ethnicity, socioeconomic status, as well as settings like rural versus urban. And so I'm going to open it up. Omar, I'm going to put you on the spot and to sort of start out. And I know in your membership, the National Health Council has so many fantastic patient advocacy organizations, and I know you talk to them a lot. And so is there thinking about any equity or access issues around this moment in vaccine policy? Share what you're hearing.
Sure, absolutely. So just to level set us, we are a membership organization comprised of about 180 different advocacy healthcare organizations, which do include our main core patient organizations. We have also partners of patient organizations. We're talking about think tanks, research institutions, and then, of course, the members in industry. What we're hearing from our patient organizations specifically is that even with these changes in policy aspects, the term of access and affordability is going to be a major issue as we go into not just the midterm elections, but also as we look into a new Congress and then also in a new presidential election. We know that trust has been eroded across, so our patient advocacy organizations are really coalescing with one another to determine what is the best approach for us to disseminate accurate and foundational information on just vaccine in general. So we're not, yes, we've discussed all day about effectiveness and so on, which is important, but I think it's more of just uptake and what vaccines are safe. And from an equity perspective, we still know that the rates of those who are of racial ethnic groups, we're talking those who are also of different language barriers, we're talking also about those from rural versus urban. There's still a huge disparity that occurs when it comes to vaccine uptake. And even after, so there's been a shift, and this is what our patient organizations are really looking into, is that disparities obviously existed right before COVID. They were just exacerbated after COVID, but there's been a huge push now with the anti-vaccine rhetoric on the COVID side that is now also influencing a decrease in vaccination rates among other vaccines. So I know COVID is our topic, but this is having a ripple effect on other immunizations. So therefore, on an equity perspective, our patient organizations are really trying to coalesce on what is that message that needs to resonate with our current landscape where terminologies like equity, diversity and inclusion, all of these are being targeted where it's not about just one specific group. It's about how do you communicate the message that it's on across the board, that everyone deserves equitable healthcare, including access to vaccines. And then when you add the mistrust and misinformation, there are being certain groups that are being targeted more specifically. I think that this is for some of my other colleagues as well to jump in, where the messaging, the anti-vaccine messaging is it's resonating with certain people. And so we're starting to see even a more decline in vaccine rates on those specific vulnerable communities. So it's across the board, Sarah. It's not just one group, but I think we're seeing a rise in that specific targeting that just became a bit more complex after the pandemic.
Yeah, I think that's well summarized, that many of us have observed that, experienced it, and this theme of messaging and the sort of the clarity, the simplicity, and again, as the communication strategy around how we rebuild trust and how we reverse that trend towards lower rates of vaccination, I think is going to be a theme throughout today. Jason, you had terribly positive body language during some of Omar's remarks, and so I want to go to you next about I know in your own research, you've been sort of looking at this like disparity issue, the distrust, the misinformation. What would you add from where you're sitting?
Yeah, I couldn't agree with everything Omar said, as my body language indicated. The one of the many terrible things that have happened to vaccination efforts over the past couple years, but that all-encompassing one is this climate of just understandable confusion. Confusion for the public in terms of which vaccines are recommended. Are they safe? Are they as safe as we thought they were supposed to be? Are they covered? If they're covered, where can I get them? In as much as there have been efforts to try and respond to everything that's come from the federal government, both in legal challenges and communication challenges and otherwise, that issue of confusion, understandably, about where vaccines fit into prevention, I think will be the work of many years to come. And to your point, I think a lot of this will start with trying to help restore a semblance of clarity and order and processes to help frankly, demystify what's become, I can imagine, sort of an impenetrable thicket of claims and counterclaims around vaccines. So that work has been happening piecemeal by the medical societies, by some, but not all, state health departments to try and counter lots of the claims and allegations and, frankly, outright falsehoods that we've sometimes seen now being championed and amplified from public health officials around COVID and otherwise, but beginning to even think now, as Omar noted, with elections looming this year and beyond, to begin thinking about the hard work ahead, not just to restore things the way they were, because we'd be kidding ourselves to say there wasn't, a long-standing group of individuals who, frankly, weren't satisfied with the evidence around vaccines, weren't satisfied with the institutions and organizations and processes that have stewarded them with great success for many years, but that idea that there was still work to be done before COVID, before this moment, beginning to think about, all right, how do we capitalize the things that did work really well for vaccination efforts, COVID and otherwise, and reimagine them in ways that address some of these systemic challenges that vaccination has been facing quite literally for decades, that unfortunately has broken out into the mainstream. So I think that's the mission for sort of vaccine access equity policy. But it starts with incremental efforts to try and help navigate this turbulence, but also then to think about, all right, how can we then build upon things that have worked well, while recognizing that the system was far from flawless, even before everything we've been living through these past few years.
I appreciate that, Jason, because I think it's so easy for us to think only about what's happened since the pandemic but we had opportunities to rebuild trust even before that. And so I like setting the bar high. So let's set the bar high for how we want to achieve more recognition. Albert, from the front lines, what are some of the equity issues that come up for you? Is it related to the mistrust? Is it related to socioeconomic status? Does it cross across a couple of these categories for you and your patients?
I will, at the risk of repeating some themes already mentioned, so
no risk there. Absolutely.
The COVID-19 pandemic, is famous for basically revealing or uncovering pre-existing disparities in care, disparities in health outcomes. And, for many of us, it was a motivation in some cases to try to really tackle long-term entrenched kind of differences in access to care, quality of care. In some cases, I know all we've done is actually get back to a bad baseline beforehand. And then the other kind of important thing to say is overall health overall health outcomes in the United States. Let's say you look at life expectancy, differences in the control of chronic diseases, or the prevalence of chronic diseases. There's this really there's a really striking public health data after the financial crisis of 2008, where life expectancy in some cases actually declined, even for majority groups. So 2010 to 20 is like a bad time, And so in some cases, this is actually far worse than ever. Since 2020 to current times, it's quite striking how bad things are in some cases. I study diabetes, and there's a particularly severe worsening of diabetes control in young people. So people who are, and some, I hope we get into this, groups that are most vulnerable don't have health insurance, are underinsured, and we've not actually, despite the Affordable Care Act, not really fully addressed that. So in any case, so that's where I'm coming from, which is that we're sort of dealing with really entrenched disparity issues in care, and then so we kind of lived through this pandemic, and health systems. So that's where I'm coming, where I work, have struggled to kind of restore and kind of get back to normalcy. The COVID-19 vaccine is just one element of that normalcy. And so in clinical practice, you see, I'll go into this in more detail if you like, but COVID-19 is not the highest priority among my patients right now. And that is kind of an issue. There's not enough time or space to tackle everything. And so in some cases, getting back to sort of basics and for some patients.
And I will definitely return to that, Albert. I have some questions coming up on sort of health system capacity. And Kate, I know that your members are hearing this and thinking about this, and so we'll get to that in a minute. I do want to say, for me, the reflection on those public health trend data really comes back to how divorced we still are as a country in thinking about opportunity costs and trade-offs, and that we are spending a lot more on healthcare than we were in 2008, and we're getting less for it. And I just, this is ICER's bread and butter, so this surprises no one who's listening to me talk, but I can't help but do this when you say that, because I'm like, of course, this is the opposite of the directions we want to be going if we are spending more. And so that really does have to do with making sure evidence is driving decisions about price, about access. It's so that we can move towards a system where, sure, we might spend more, but maybe we're going to get more out of that in terms of health. And so I really appreciate you raising that, Albert.
And just one last point, which
Please.
is that there's just been I don't know how to, a K-shaped economy. I don't know. So you have growth in the health system, and for those of us for health, the cost of health care. But I think at the same time, we've had, I think there was a surge of public health of funding for public health during the COVID-19 pandemic, but now kind of questions about the size of the public health system, which was part of, and so who is, ultimately these things are becoming more intertwined. I think healthcare is taking on more of a responsibility for delivery of vaccines, but it can't do it alone, and it needs a public health partner as well.
Yeah, I think that's an important point to acknowledge in terms of what's happened to our public health infrastructure, even in the last 18 months, as we've seen a reduction in the number of people employed by governments to do this important long-term work. We talk a lot at ICER about the long game, and that some of the work of achieving a more affordable, just healthcare system takes a while. And that's true of public health, and the infrastructure that was there, building relationships in communities, trying to rebuild trust, has really taken a hit over the last 18 months. And so I think that's an important contextual point. Lee, to you next, in terms of disparities. Now, your population that you represent, older Americans, has their own sort of challenges in terms of health status, access, etc. But from this issue of health equity or disparities as it relates to vaccine access or understanding, what are you seeing?
So just broadly, kind of level set, I do think in some way, at least the population that I represent is on a little bit better ground, in the sense that they are the population who seems to have gotten the message that COVID vaccines are something that they perhaps should look into, and they do have higher rates of utilization. That said, we also represent the 50 plus population. It is not obviously the same for the 50 to 64 population. And there are also some changes. And I think the biggest issues there are related to what has already been raised, which is insurance. Looking at what's happening in the healthcare system and the changes that have taken place, there is a significant part of the demographic that we represent where there are concerns that going forward, they're not going to have affordable access to these vaccines should they want them. And that is obviously going to be a challenge. It wasn't that long ago that everyone had access to free vaccines, and now we're facing, someone paying a full cost out of pocket. So I think that has definitely been something that we have been paying pretty close attention to, just looking at simply access. The other aspect of it, I think, that has been challenging has been kind of just going back to those ages and people's perceptions of risk. And as a consumer organization, we have typically relied on federal agencies when we're trying to share information. The FDA says this, the CDC says that. And there have been some decisions and actions lately that, as we've already mentioned, have been called into question by experts. I'll put it that way. Interesting, we'll use that word. And that has made it really challenging for consumer organizations who don't weigh in on the science and don't weigh in on the economics and are just looking for reliable information about how to direct the people who are coming to them for information. And that has been a real challenge as well. It really speaks to the importance of having someone within the healthcare system that is providing that sort of evidence-based information that is now unfortunately being called into question.
I appreciate that point too, Lee. And I think that it's the overarching thing that's happened, right? To create the challenging situation, the turbulent times, the interesting. I've got 3 so far on my list, and I will keep adding throughout today's conversation about what are we to do if you had a system. And Kate, I'm going to come to you next on this because I'm kind of jumping ahead, but it's worth kind of addressing this now. We had kind of a great system where ACIP got together, made a recommendation endorsed by CDC, and the payers ran with it, and there was no cost sharing. And now payers are in the situation of, well, I don't have that anymore. What am I doing? So why don't you brief just catch everyone up on how the health plans have been responding to that uncertainty?
Yeah, thanks, Sarah, and thanks to my colleagues on the roundtable. First, I'm going to say that the health plan industry has made a commitment to cover the recommended vaccines through 2027 with no cost sharing. Now, of course, to the points that others have raised, that addresses people with insurance. Okay, so that's like no cost sharing for people with insurance, vast majority. So I feel like, we did that last year. We updated it recently through 2027 because we wanted to take that issue off the table, if you will, as a barrier. Now, that said, I will also add, we've all looked to ACIP for a very long time. So we've all talked about like that process has been disrupted. It's turbulent, like whatever, Sarah, you want to use, whatever terms, it's been disrupted. And by law, by the way, health plans have to follow ACIP. Now, however, I will add to that plans are very accustomed to reviewing multiple sources of evidence to make their decisions about coverage. And of course, everyone knows too that like states have gone their own ways. Many states have decoupled ACIP and they're doing their own thing. And so plans are complying with whatever the requirements at the state level or their other customers might be requiring of them, federal, state, et cetera. So those are a couple of important considerations. And there were conversations earlier about confusion, mistrust. We really, the health plans, like the chief medical officers who lead these teams, who address the evidence and engage with others across their teams, they're very worried about this issue of, different information, declining vaccination rates, not just COVID. By the way, beautiful report to the team. Thank you. It was clear. And obviously, for the populations, the most vulnerable populations, these COVID vaccinations are really, really important, specifically for those most vulnerable populations that have been discussed. But we know that there are so many people, even before, by the way, even before the sort of like the last couple of years, the COVID vaccine rate was like 20% overall, right? So we know that there are issues about like people don't want to do these things, and it's not a one size fits all in terms of addressing the issues, the concerns, the confusion that people might be experiencing.
No, I appreciate all of that. I think you're right that, and it's a good reminder that the goal is not to go back to what it was 18 months ago. Like, we're going to raise the bar in terms of what we want to achieve, in terms of rebuilding that trust and countering some of that misinformation in service to these public health and population health goals. Kimberly, because I don't want to get in trouble with your mom. Kimberly, the way that I know New York Medicaid well. We've worked with other Medicaid departments. You can't work at Medicaid and not think about health disparities and health equity. And so, however you want to share for this audience as it relates to vaccination uptake or issues that are top of mind as you guys are thinking about your own policies in terms of access to the vaccines, please share.
Yeah, I mean, I think, New York Medicaid serves roughly 7 million members in New York State. We were hit really hard during COVID. I think as a state, we recognize the value of, a healthy population and the value that immunizations and vaccinations provide. So that is first and foremost in our mind. It is, one of the main principles that our Commissioner of Health really has us all moving towards is increasing vaccination and increasing access. That said, it has been difficult the last 18 months. We have pushed a lot of the responsibility for vaccination to mid-level and in some cases lower level providers to try and improve access. New York has also had to make a lot of legislative changes. We have moved away. We had a lot of legislation that was that had ACIP requirements embedded in it, whether it was insurance law or public health law. So, we've added 4 other medical organizations and the ability for the Commissioner of Health to make recommendations. But again, we're going to have, 5 potential sources contributing information, which I don't think eases that burden of confusion to our members and to our population. So it's something that we really, we have to be aware of. We luckily had legislative changes. New York has always been supportive of, insurance plans covering vaccinations at no charge. We, as a state, need to look at other ways to improve access. So whether it's counseling, whether it's improving access through vaccination clinics or other opportunities, but it definitely is a challenge, especially with a diverse population like we see in New York.
Yeah. Kimberly, I appreciate all of that. And you've touched on a few things we're going to pick up. We're going to talk about the health system. We're going to talk about sort of more about the payer coverage landscape, what the future might hold, future research needs. But I appreciate that that's all connected to how we're moving forward from this moment of uncertainty in service to better and more affordable access. Before we dive deep into a couple of those areas, though, I did want to give the panel an opportunity to reflect on any of the votes that we heard today and whether something surprised you or didn't, or any context that you'd be interested in sharing. Just a quick review, the special ethical priorities, yes, race, ethnicity, socioeconomic status, frontline workers, healthcare workers absolutely came through clearly from the votes of the council. Clear votes that the evidence was adequate for most populations of a net benefit, with a split vote for males 12 to 24. which may or may not be surprising to those who've been sort of following along. And then clearly support for these vaccines being high value. And for those who are listening, our Chief Medical Officer, David Rent, made a joke earlier about, well, how often do we see cost effectiveness ratios like this? The answer is not that often that we actually see prices in line with value. And so I think that is something to be celebrated and commended, that these are, even with small gains in health, again, small costs associated with those gains gets you the same sort of ratio as big gains and big costs. And so 5 high, 8 intermediate in terms of the value votes there. So anything that either surprised or didn't surprise anyone on the panel who wanted to chime in about the votes that our CPAC took today? I almost feel like I should start with Jason and Albert because they have sat in the chairs of those who need to vote and make those. But Jason, how did it feel to have to watch and not be able to vote? And what did you think about the vote today?
I thought it got, even though, as we noted throughout the day and will continue to, the CPAC was not making public health recommendations. I thought the nuance in terms of how to think about the evidence and what it meant for different populations, what we knew, what we didn't know, gets to one of those big challenges that policymakers, ACIP, others have to figure out when it comes time to translating evidence appraisals into recommendations. And there's often this critique, accusation against vaccine policy that these schedules are one size fits all approaches. And that's not true. There's lots of nuance and special circumstances built into the schedules. But at the same time, what we saw during the deliberations was this point of saying that even for particular vaccines, the risk benefit uncertainty profiles looks differently across age groups, across comorbidities, across other factors where we have signals or we don't have signals or we wish we knew more. And it gets at that complexity that I think our policymakers have to face, even in good times, let alone in these times, of trying to figure out ways to create public health recommendations that are clear, that are understandable, that don't create confusion or uncertainty, or don't lead the public to throw their arms up in the air and saying, I don't know what to do or whether I should get this or not. Yet at the same time, appreciate the fact that these population level recommendations are really, really hard. And I thought just the nuance of both the analysis and the votes got at some of that underlying complexity that sometimes gets washed away when we just look at a grid or a chart of a paper in terms of what's recommended. So kudos to the team for that.
I appreciate that, Jason. Albert, anything surprise you observing the votes today?
I actually was happy to not have to vote and just watch the process because they're each of the vote. They're each complicated questions and there's a lot to wrestle with. I guess I am sort of surprised at the kind of mix voting on the value question because this is a low incremental cost effectiveness ratio. So most of the time you would say this is highly cost effective or really good value. But they must have, I would love to know what they were thinking. They must have been wrestling with what Jason talked about. They must have been thinking about, this is the value for the overall population, but maybe there's some hesitancy because of the mixed evidence. And we're relying really heavily on this one VA study for, I wish we had a whole series of trials. And maybe this is a hint at what I'm going to say later about what future researchers needed. But yeah, I was surprised by that.
I think that reflection matches a bit of my own, and what I am gathering from that is also what we modeled, which was to sort of the FDA label versus what might end up happening, a public health recommendation that says everyone get vaccinated. Scenario 6, my memory, shares. They had different results. And so and then if you look at the comparative effectiveness votes and you see that for some populations, there was a little more nuance there. I think that's what was sort of coming through. It was coming through that this is hard. And judgments of comparative value are not meant to be easy. And that's why we do a 6-hour meeting to talk about it after an 8-month process. But I appreciate that reflection, Albert. Anything else from the other? Please.
I was going to say one more thing. I actually really like the fact that the question is about now.
Yeah.
And not the past. It was just we have to make a decision now. And the world is different, the populations are different. And so I like that. I really appreciate that. Frame.
Yeah, and I think I appreciate you bringing that up too, because I even struggled with that as I was participating in the development and reviewing of the report over time. And I was like, oh, right, this is not January of 2021, where things felt very different and the data were telling us something different. So yes. And again, this is, I think, how we rebuild trust is we tell the truth about what's happening now and what we know and what we don't know. So just an invitation for any of the other roundtable members, any reflections on the votes. No pressure here.
Yeah, I mean, I'm happy to chime in just a little bit. I mean, again, having not observed that before, I was very impressed with the deliberation of the committee as they thought about how to weigh in. And it was so interesting that some were really like unanimous and some were like totally split. So I think that shows that ICER did a wonderful job of kind of balancing all, like, let's face it, we don't have the clinical trials. Like, you used observational trials, really made conservative estimates and extrapolations, and everyone had to grapple with that. And I mean, that just shows like evidence isn't always perfect. Usually it's not. And that's why it's so important that a body like you guys, like in the absence of an effective ACIP at this moment in time, that ICER and others are stepping in to kind of fill those gaps. Even though you're not making public health recommendations, it's still really, really valuable to have that dialogue and to communicate the findings of the group.
Thank you, Kate. And we work really hard on developing those questions, and sometimes we ask questions that we know are really hard. So that there is that opportunity for the back and forth and maybe a split vote, which helps communicate something to the ultimate decision makers about what the evidence is telling us and what it's not. Lee, I think you were going to jump in on that.
Yeah, and again, I'm starting with the preface of I'm aware I represent older adults. Research is very different from us, so I'm just putting that out there. But I was really struck by the fact that about, I think it was Joe's question about the 65 plus population. Is it people with chronic conditions or is it just normal, quote unquote, 65 plus? And I think that's really important to draw out because when you look at what's happening, for example, with the CDC, how they define those populations is really important. One thing we have heard is, for the under 65 population, they might say, okay, well, it's a good idea for people who have these risk factors, these chronic conditions. And then we hear from someone who says, well, I have hypertension, a bunch of other things, but that doesn't apply to me. And so finding ways to define it in ways that people recognize themselves as they may fall into a risk category, I think is really important as part of this process as well. But it also just speaks to the complexity of the populations you're talking to. And going back to what Jason said, it's very difficult sometimes to set up some sort of recommendations and guidelines for a population that has as many kind of complicating factors as most do.
And just like a human moment reaction to that too, Lee, is also that sometimes you don't think that's you as a patient, right? Like we don't all see ourselves as our chronic conditions or our comorbidities. And so there's also just an aspect of like the education and the understanding that we build when we say, yes, you are one of the people who definitely should get it because you have this comorbidity. And you're like, oh yeah, I forgot I had type 2 diabetes or whatever it might be. I don't mean to be flippant. I just know that it is like a human thing to not necessarily think about that all of the time. Great. Any other reflections on votes before we move on? Okay. For the next couple of buckets, I'm gonna try to have us focus on actions and solutions, right? So we've identified some of the challenges. It's come up throughout the day. We've got mistrust, we've got misinformation, we've got low vaccination rates. But there's a couple of themes that came through today. I just want to get your expert reaction to on how we could address some of these challenges. So the first one I want to start with is the federal infrastructure has long ensured a connection between the expert recommendations and payer coverage, and that's been in flux. And so Kate has already given us the commitment from the payer community to continue to offer these vaccines without cost sharing, which is great. But what can we all be doing to ensure that remains? I will admit to some nerves about a voluntary system and its sustainability when I see headlines every day about how healthcare costs are just going up. And so, is there, how are you all thinking about supporting this voluntary infrastructure for now? So Kate's demonstrated that sort of commitment that's coming from the payers. Um, uh, Omar, let me start with you. Is this advocacy from patients? Is this talking to legislators? Is this, how do you see the sort of payer advocacy community participating in, yes, please continue to offer vaccines with no cost sharing in our sort of current voluntary system?
Absolutely. I think it's a combination of all, Sarah, and
Yeah.
it's not just one. So I think it is the advocacy component from patient organizations. They have so much influence within the legislators to help steer the needle forward. It's not necessarily that it's the panacea to everything, but definitely I think they have a way of moving through the legislator. Definitely, we've known that the storytelling of all patients who are, impacted by certain policies is, of most important for legislators to really make an impactful change. But I think it's not just thinking from the federal perspective. I think it's also from the states. Everything is regulated differently at the states. And so we are doing a greater push to determine what is happening at these states legislators where, some of them are going to be impacted by the ACIP, changes. And of course, they have to figure out how they're going to navigate those costs, but also understanding that after the passage of HR1 or the One Big Beautiful Bill Act, where 17 million people are going to become uninsured, and also states now are trying to figure out how I'm going to cover all these individuals that are going to lose insurance. So we're talking about those insured, but then you also posed a question earlier about those who are uninsured. So now
Yep.
states are also battling, how do we do that? So I think there's definitely a role for patient advocacy organizations to mobilize and empower the patients to really bring forward these realities that still exist for those that are more vulnerable. And again, we want to move the conversation away just from vulnerable being race, ethnicity, sexual, preference, everything, whatever it is. It's more of just I am in a position where I'm at risk for X disease, COVID-19, because of just where I reside or where I live, right? So I think it is aspect of advocacy, but then also too, Sarah, is how do we arm our patients to have the right messaging? So it's not just the advocacy, but it's the communication. So at the National Health
Right.
Council, we really took it back to Public Health 101, and it's building these public health campaigns on the trusted messenger role, meaning I am going to find someone within your local community to talk to you about why vaccines, why coverage, why X, you name it, it's so important for you to be aware of, and why your story is important to move, certain aspects in policy forward. It works. I think as a society, we tend to overcomplicate things when they get so disruptive that we want
Yeah.
to, just think about where do we go?
Mhm.
Taking it back to the basics is so helpful. And I think that
Yeah.
that's what we've learned so far with our Trusted Messenger program is that you could take any type of topic, and if you really find the route that is so simple to communicate, it's going to move so much forward than you trying to, you know, uh, basically uh, tackle every single issue at once where it's not helpful. So,
Yep.
really taking it to the simple state has worked wonders for us. And we've seen a great progress in terms of different states who have had of low chronic disease management, vaccination rates. If you target it specifically to certain communities with the respective communities, the message works.
It works. That's a great, I mean, I think that's going to come through in our write-up. Omar, is sort of and we'll reference your trusted messenger program, but sort of the simplicity, like the building relationships, the simplicity of the message, the clarity of the message is so important. I want to just spend a minute on the uninsured, and others can sort of chime in on roles they think their communities can play in sort of making sure we keep this as a no cost sharing situation for those with insurance. But given we're going to see a rise in the number of uninsured, you know, we spend a lot of time with manufacturers on other reviews talking about some rare conditions, some serious conditions, sometimes with high cost medicines. And they talk a lot about their patient assistance programs and how that's a way that they can make sure patients with adequate health insurance coverage get access. And I'm not sure we've ever needed to have that for vaccines. And so I wonder if that needs to be something we put on the table, and that the manufacturers themselves can contribute to ensuring no cost sharing or no cost access for the number of uninsured. I'm happy to take any endorsements of that idea, but I'm not putting any of you on the spot to say whether or not you like it or not. But it occurs to me that there is an infrastructure that exists in most of these manufacturers to give free product to other products. And so this might be a way we have to sort of bridge the gap while the uninsured don't have no cost access.
I mean, there is
Go
the
ahead, Kate.
vaccine for children's program, at
That's
least
right.
for part of
That's right.
the population, right? So
That's right.
for uninsured, underinsured, I mean, that's like one safety net, but that doesn't, I'm not really answering your question, Sarah. I just wanted to
No,
chime
but
in
it's
on that
also a
one.
good analogy and allegory that we can sort of have in there, that there is a precedent of sorts with the vaccine for children's program. Jason and then
Yeah.
Kimberly.
And it's been a precedent, Sarah. The Vaccines for Children's program has done wonders, right? Covers more than half of America's children, as Brett noted, 30 years, tethered to ACIP recommendations precisely because the thought of Congress was that would take it out of the sort of political budget process. Trust this, at the time and for the longest time, sort of a non-political bunch of experts to say which vaccines are essential, and then an entitlement program that would direct Congress to find the money to get those vaccines. And it's done wonders. The Biden administration tried in its budget for its final few years to create a parallel vaccines for adults program to serve that same goal for the 25 million or so uninsured adults, because that's the one real weak spot in our vaccine affordability safety net. It's a patchwork like everything in our healthcare system, but through the ACA coverage requirements, and kudos to AHIP for providing stability for this time, the VFC program for kids, Medicare and Medicaid requirements that are increasingly linked to ACIP, but uninsured adults, there isn't anything to facilitate access at a time when adult vaccination is becoming more prominent and more expensive, not just COVID and flu, but pneumococcal and shingles and RSV. So that's an issue that's been one, like my sort of theme where I started before COVID, to be sure that folks were aware of, but given trends, uncertainties, turbulence, interesting times, even a more acute issue. And there just aren't funds even for states to try and fill those stopgaps for, what are really sizable and growing investments for, like I said, almost 30 million Americans and a number sure to grow given what's changing with Medicaid.
And Camille, as we go to you, this is not the moment to be asking states to come up with more money and do more things. Like just acknowledge that where we are right now. And I know you're living that every day, but please chime in on this.
Yeah, no, I'm glad Jason mentioned, the Biden initiative and, kind of using that vaccine for children model, which has historically been really effective, particularly in a state like New York, to get vaccines to that 19 and under population. Using that, getting manufacturer buy-in, I guess, is what we really would need to actually use that tried and true distribution system and roll it out to the older populations and for the uninsured. It is hard to develop systems to get product and to get availability. We've had some brief conversations here where we talk about something like you said, a patient assistance program, but there's always that concern about the missed opportunity, right? A patient assistance program requires reaching out to the manufacturer, coordinating all of that. Where, if it's something a provider has in his refrigerator, able to give it at the time the patient's willing to take it, that type of access makes all the difference in the world in terms of getting patients immunized.
Kimberly, I really appreciate that point. Just the infrastructure piece of the best time is when they're in the doctor's office. And if you aren't able to know if they're going to be able to get it for free, if they're uninsured or underinsured, whatever it might be, you might have missed your entire opportunity to vaccinate them for the season because they're not necessarily coming back. Omar, please.
I think your point about fee assisted programs. I think the conversation is also just not getting the vaccine, right? So it's like that's one piece of it, but there's this other component about the affordability barriers that exist to getting the vaccine. So what happens if it's a child or it's a mother of a child who is a single parent who needs transportation, who X, Y, and Z, right? So it could go down the line. So I think it's
Totally.
not just about offering a free vaccine. It's about how do you even get to the vaccine. So I think we need to really think that coverage it's without access, it's not complete. So we really have
Yeah.
to think about the delivery systems. And I know you might be going into this conversation, with our clinical experts is,
Next.
how are we meeting patients where they're at? How do we go to the communities? How do we ensure that we are doing, the best effort to ensure that the vaccines are getting to them? So say manufacturer says, yes, great, we have these vouchers, we have this for free. All right, but then how do you get it to the hands of those that are of greatest need? So
It's
thinking
a
about the
bit
equity issues, right? The big broader piece too about these barriers that exist.
It's a fantastic segue after Albert, you chime in. I do want to get to sort of the health system readiness piece and how are we thinking about the system. And spoiler alert, I'm going to talk about the role of pharmacists and how we're using them in this instance. But Albert, go ahead.
Yeah, hopefully I'm not preempting anything you're gonna
Go
say,
ahead. No, no, no,
but
it's fine.
as we were talking about the uninsured, um, I am not confident about the state of affairs right now, but clear the one place where this um, the delivery could occur is, of course, the federally qualified health centers. So the
Yeah.
Bureau of Primary Health Care, and I know that during the pandemic, they played a huge role in expanding COVID-19 vaccine delivery, but I don't know the current state of affairs and how I don't know how county and public health systems are also. I was just looking at my own Cook County system here in Chicago. They are, they have recent postings about offering COVID-19 vaccines. I don't know how they're purchasing it and how they're affording it right now. So these are and so these are the places where the uninsured will have to get vaccinated probably.
Yeah. No, those are great notes in terms of the infrastructure. Lee, go ahead.
Yeah, I don't want to lose the affordability because obviously that's hugely important. But the other part of it that's really important is really on the access side. I don't know if everyone remembers, but last fall there was a lot of discussion about, oh, you're going to have to get a prescription before you go to the pharmacist in order to get your shot. And so there are administrative burdens that can be placed on people to have access to this. And if you are uninsured, there's a very low chance you're going to go to a prescriber to get a prescription before you go to the pharmacist. And so there are other parts of the system that can become barriers beyond just the cost. And I'm sure we'll get into that more on the discussion of the pharmacies, but I just want to make sure that was part of the conversation as well.
Well, yeah, no, I wanna go to health system readiness because in thinking about this issue and talking to experts, including yourselves, in the lead up to this meeting, um, uh, there was no COVID-19 vaccine available at my doctor's office. I could get the flu vaccine last fall because there was an issue about like where to get it and how to get it and did I need a prescription or how could I get it? I figured it out. There were issues around there are issues around how much more time it's taking to counsel people on vaccination. And I bet Albert is not excited to have more things to spend time on in his very short window of time with his patients when they come in. And so there's also this is straining our already strained primary care ecosystem because you need more time with the patients to talk through their concerns, to build that trust. And it's all in service to something very important, but it's coming at the expense of time to spend on other things. And Kate, I'm going to you first. Are providers coming back to the plans and saying, and we need more reimbursement from you in order to do this as part of our work because we're spending more time? Or have you heard from the provider community as it's bubbling up to the payers about this health system readiness and capacity issue?
For sure, right? So even our CMOs who still practice medicine, they talk about like how much more time it takes to build trust and like to, turn something around, if you will. So yes, I mean, I'm not the coding expert on our team, but my understanding is, and I'll defer to others if there are folks who know this, but my understanding is there is a code that adds some reimbursement for providers for that counseling piece. So totally recognize, especially with kids, parents, like in that kind of like family situation. That's probably the most important place where that additional time and trust building and answering questions is most critical.
And thank you for mentioning. We'll look
Maybe
into
not totally COVID, right? Like so beyond
sure.
COVID, but for sure.
With that vaccinate, well, right. So if there is a code that can be added for vaccine counseling, like we'll make sure that we mention that in our write-up because that is one actionable way. Kimberly, go ahead.
Yeah, so there is actually a code that can be used for vaccine counseling. It's in the 9900 or 99,000 series. We've used it here in New York State for the last couple of years to encourage counseling both by the practitioner and the pharmacy. We have found that pharmacies are really good partners in terms of providing vaccination services. And New York has made a concerted effort to make sure that prescriptions are not required for standard adult vaccines and also for influenza and COVID vaccines for the 2 and up population. We do see it as an important area of access. This is the place where a lot of patients go week after week. So there are greater opportunities there to develop a relationship and an understanding between the pharmacist and the patient. And it also should be alleviating some of the burden that we have for the practitioner communities.
Yep.
One of the things that we've done in support of that is to make sure that we have commissioner authorized standing orders that are available for all of the vaccinations so that that's not an additional burden for pharmacists and pharmacies that want to provide vaccination.
Excellent. We're going to mention that for sure. Yes. Sorry, Kimberly, did I cut you off? I apologize.
No, I think having the requirement to get a prescription creates a ton of confusion. It decreases access. We really saw that as a burden. So we've tried in many ways to eliminate that.
No, I'm excited for some of the actionable things that we can put into the policy write-up that will talk about there's a code that you can use. You can have standing orders so that pharmacists can do this. When I started at ICER a while ago now, I had been in healthcare for a while, but I had never had the opportunity to work closely with pharmacists. And my only experience with pharmacists was at the pharmacy counter. So I thought of their role as pretty narrow. I will admit. I have such deep love and affection for clinical pharmacists now that I understand their vital role in the healthcare system. And I think this is just such a wonderful opportunity to elevate a clinician in our system who can practice at the top of their license by administering vaccines when you can facilitate it with things like no cost sharing, standing orders, etc., to take some of the burden off of some of the other clinicians who are dealing with things that are in their licensure. And so we'll make sure that we elevate that and experience that. Albert, I did want to give you a chance just in terms of anything you want to share about what it's been like to have sort of new responsibilities around vaccination counseling as you're, in your primary care practice. Is it you have seen that it takes more time with some patients to be talking through the pros and cons of vaccination or not terribly impacting your patient population?
Well, I think the bigger context has already been referred to, which is that COVID-19 vaccine is actually just one. So just in the vaccination space, that's actually just one of the vaccines that we as primary care doctors have to counsel people on. So every fall or winter, we're also contending with making sure people get their flu vaccine. Actually, the pneumonia vaccine has become a high priority now with the effectiveness of Prevnar 20. On top of that, we are now, when I take care of older people, we have to also think about RSV. And then, in the last couple of years, we had monkeypox at one point. I mean, so the number of infectious diseases that we are thinking about, and actually Omar made this really great point, which is that we as primary care physicians are worried about just missing, we're worried about mistrust in vaccinations as a whole. So in some ways, we want to get some wins when we interact with people. And so I'm going to go, and so if I know my patients well, I'm going to try to recommend something that where I can get a win. And I can get some shots into arms before the person leaves. And sometimes that means if I know the person already, I may leave off COVID-19 because I'm trying to get that flu and Prevnar 20 into them in that day. So that's if you view the time of the doctor as a constraint, but as Kimberly talked about, the availability of pharmacists to get vaccines into people, that expands time, space, other places where people can get their vaccine. I think in my own family, I think my own daughters and my wife, they all gotten their COVID-19 vaccines or flu vaccines at pharmacies, not in the clinic. So that helps a lot. But yes, we're contending with a lot in primary care. We have a lot of responsibility in a short period of time. I kind of laugh at all these additional codes that we can add. Because there's I honestly, with my older patients, I can also code for advanced care planning. I can code for, but honestly, those codes don't. I'm not sure the remuneration is high enough to in the end really address this kind of problem of a limited resource of time and tr ultimately trust. And I'm just dealing with.
Albert, don't worry. There's
Yeah.
an AI tool someone will sell you
Oh,
that
I'm
can
sure.
help with that.
I'm sure. I'm sure. But let me just let this
Please.
still really live in a fee-for-service system, and
I know.
that's the kind of world we're talking about. And it kind of is terrible.
Yeah.
So clearly you can tell from our health systems, my own health system, they are struggling a bit with revenue and the rising costs of nurses, materials, doctors. And so I can't tell you how often I'm being reminded to do certain kinds of codes to generate more revenue. There's
Yeah.
something amiss in the
Yeah.
with the revenue and costs in our systems.
I am so glad you said that. Could not agree more. While I'm happy there's a code that exists so you can be reimbursed for your time counseling someone on vaccination, it also is such a symptom of a problem, our fee-for-service system that's not reimbursing holistically for providing healthcare. And so there might be a sentence in there that talks about that. Sure, there's a code, but also moving to a system that pays for value and not one that just pays for codes is also likely to benefit.
Well,
Omar, did I
uh,
go?
yeah, to add to Albert's point is
Please.
that, clinical experts like him and others in this call today really uh, are the essential translators to building trust as well. I think, to the shared decision-making process of things, our past research at the NHC has showed that even till now, this day, that shared decision-making, that opportunity for patients and the clinicians to come to a conclusion of what is best for them, but also identifying what are those treatment trade-offs, right? If I do this, what does it mean for me? So I think that there's still such a valuable opportunity that clinical experts have when they have that 15-minute, well, maybe 15 minutes too much. Let's say 10-minute, up to 15-minute time that they have with patients in order for them to tell them and educate them about, the safety of vaccines or whatever it is that you're taking that time, right? But I, I think there's such a valuable opportunity, but it does go back into, is 10 minutes enough? And then if you add more, then there's adding additional layers of costs to your visit and so on. But I just wanted to, at the point that shared decision making is so important now, and patients are valuing where we're at, an essential part of their healthcare experience.
And I think in this moment, Omar, if we're moving towards a risk-based approach to some of these vaccination questions, whether it's COVID or other, that takes conversation across the patient demographics, whether it's somebody with a ton of privilege or somebody without. And
Right.
so, and I don't know that our system, I know our system is not well designed for that type of conversation. I think that's another way we can frame some of the changes we could potentially see in the broader system that would support a healthy vaccination policy. So it's the 20-minute warning. And so this is my opportunity to tell you your last comment. I usually say you get a magic wand and you could like wave it, or you could tell someone in the system to do something. But given that we've been very intentional about our role here, we're talking about comparative effectiveness, comparative value as one or two inputs into the things that will be considered by the bodies that are going to be making recommendations, the clinical societies, the public health leaders. So I'd like you all to start thinking about your final comment here is, what advice do you have for those clinical societies and those public health leaders as they're crafting recommendations based on what you've heard today? So that's your 20-minute warning for your final call to action. But I did want to spend some time here on future research needs, because this really came up today and we relied heavily on observational study. There was no RCT. I don't think we should expect too much from RCTs. Maybe we will, but maybe we won't. And so let's develop sort of a wish list from where you sit about where you think the most important unanswered questions remain about the comparative effectiveness of the COVID vaccines. And Jason, I'm going to put you on the spot and start with you.
Sure. No, I mean, I think it's a truism in these meetings that we always want to say we wish we had more evidence, more better evidence. But it's true for vaccines in two ways. We talked a lot about the limited evidence around effectiveness today, a little bit about safety in the myocarditis story, and we've got amazing evidence for vaccine safety generally, despite all claims and allegations to the contrary. But even before this period, even before COVID and these last 2 years, really reputable, serious vaccine safety scientists were saying, clearly all the systems that we've got, strong as they are, robust as they are, the confidence that they give us, are clearly, insufficient to fully persuade a small but growing minority of parents who think, parents in particular, we don't have the evidence that we need to allay fears about the unacknowledged harms of vaccines. And I think as we think about what comes next is figuring out, candidly, all that's worked about all of our vaccine safety systems, the passive surveillance, the active monitoring, their interacting strengths and weaknesses, but say, where can we invest? Where can we invest thoughtfully in new models, new systems, new structures, new entities to double down on vaccine safety science? Because so many of our societal crises around vaccination does boil down to this question about, are these vaccines really as safe as the public health medical community believe them to be? So I'm all for celebrating all the work that has given us such confidence in vaccines, but really figuring out what more can we do to try and stem this tide of growing numbers of parents who say, I want to see more, and I don't believe what you're seeing me right now. And that's another tough hill to climb, but I think it's one we have to confront going forward on the evidence front.
Thank you, Jason. Kimberly, what's top of the list for you for future research needs?
Wow. I think we really need a coordinated approach to providing and actually determining vaccine schedules. And I still have significant concerns that, when evidence wanes in a particular age group or a particular area, we run the risk of maybe the American Academy of Pediatrics and, ACOG having conflicting recommendations on vaccinations. And, how does that further decrease vaccine confidence? I think part of it is, not having engagement from the actual manufacturers, where they're robustly, researching and determining that these products are indeed safe and effective. and giving that value added and that information to practitioners so that they can share it with their patients, and so that we're all working from, you know, the same platform of knowledge and messaging going forward. You know, I think anytime we have bifurcated messages, anytime we have variation, anytime patients are hearing conflicting information, or encountering barriers, those are all opportunities where patients will make a determination that's maybe not necessarily in their best interest.
Yep. I appreciate that.
Yeah.
Yeah.
Thank you. Kate?
Yeah, am I okay? I'm off mute.
Yes, I
I'm
can hear
happy
you.
to chime in, and I appreciate
Yeah.
Kimberly and Jason's points. I do feel like, you know, the evidence is sort of clear, but I'm not sure that translates to patients. Right? Like, even if we know, okay, you guys did a great report, like COVID vaccines, safe, effective, most effective for certain populations, like excellent. But it's not going to translate to patients, even though you bend over backwards to engage every stakeholder, right? So I sort of worry about how, you know, and by the way, the best evidence isn't going to change some people's minds.
Yes.
So we just have to acknowledge that and
Yeah.
figure out like how and whether we can really address that and who can address that. So just another 2 cents on that one.
I appreciate that, Kate. Lee, what's top of your list for future research needs?
I actually agree a lot with what's already been said. For me, it's not so much specific to what's been discussed today, so much as figuring out what sort of research is going to be persuasive and from what sources. Because I think it's just those basic vaccine hesitancy questions that have been dogging us for so long that we have not quite figured out how to answer, and unfortunately have gotten worse in recent years. I think that's most important. And I hate to say this, add this to the mix also, but like in a world where research funds are finite, you really want to make sure you're spending your money in the right places. And so kind of doing that messaging, you know, what actually is going to help people, bring people along in one direction or another, I think is probably the most important step at this particular moment.
I appreciate that. Omar, what's top of the list for you? Future research needs?
You know, just given what the report found specifically with pregnant women, I would say hammering down a little bit that and disaggregating the data by different ethnic groups. We know that Black women have higher mortality rates, specifically in pregnancy. So I would say trying to augment the research in that area. I think that would be at the top of my list. So it, crosses equity and it crosses, pregnancy.
Thank you. Albert, how about you?
All great, really important points already made. I was struck by just a lack of efficacy trials in certain age groups or subpopulations, and I'm sort of confused by the whole field because I remember reviewing flu or pneumonia vaccine trial, and they do these trials. They just do straight up efficacy trials, and we seem to be missing that. I think that's considered gold standard science, even in this administration. And I think those need to be done. But like actually Lee and others have said, the whole science around public health messaging is still like we don't know how to do it well. I thought there was a movement towards like this idea of like hyper segmented messaging, so certain groups get certain kinds of messages, but I don't know if anyone's made a breakthrough in terms of how to do that well. But that's kind of the world we live in, a very hyper segmented population with people hearing things from different sources, but I think that's probably what public health of the future needs to do.
It's not a competition, but I do want to say you are the first roundtable to come up with future research needs that did not overlap with the list that I had already written down. And so now I have my list and I have your list. And so you guys get an A+ for that, because my list includes information about whether vaccines help with reducing transmission, right? We had a lot of questions about that today. My list included more of research on the role of vaccination in people who are immunocompromised, right? Because I think that was a population that really came up. Frontline workers, healthcare workers, which ties to the transmission question, was on my list, as well as vaccination frequency, which I think, we all just treated it like flu, like it was seasonal and it should be once a year. Is that true? Should it be twice? Should it be once every 2 years? So we'll add that to the list in our write-up, in addition to all the fantastic additional recommendations that you guys came up with. So sadly, we're into the last 10 minutes here. And given that I have high expectations for the robustness of your recommendations to the clinical societies, I do want to give you all sort of the final word as we think about everything that we've heard today throughout the deliberation in the meeting and the discussion today about future research needs, health system readiness, the payer coverage landscape, how to deal with the uninsured. This is all meant to be in service to the experts at the clinical societies and the public health agencies who are now going to make recommendations about the COVID vaccination this fall. And Kate, I'm going to start with you. What advice do you have for the clinical societies and the public health leaders who will be crafting recommendations?
Yeah, thank you so much. What a great conversation. I'm going to say, like, we need to build on all the multi-stakeholder groups that are already in place, right? So, Common Health Coalition, ICER, of course, the Vaccine Integrity Project. Who are already coordinating, like the medical societies and others, to kind of come up with the best recommendations and to figure out how best to communicate. Like, there's a project underway in that regard. So I feel like we don't need to invent a new wheel. We do need to make sure that we're all leveraging all the efforts that are underway already. So thank you. That's my 2 cents.
Thank you. Kimberly.
Yeah, I think that's exactly Kate. What Kate is saying is exactly right. We need to make sure that we're not maintaining silos professionally and across associations, that we're looking to collaborate and find some consistent messaging. I think that that's really key to moving forward.
Thank you, Kimberly. Lee, advice for the clinical societies and others making recommendations.
So I've been working in policy for a really long time, and I'm aware that this is a very big umbrella, but it kind of encapsulates kind of everything that I would say, because there's obviously a lot of work that needs to be done. So just starting from the basic premise of these products have been confirmed safe and effective for you. If you want one, you should be able to get one. And so everything that needs to be done in service of that to make sure that people have access to the vaccines that they want. And again, they've been proven safe and effective for them. That is the sort of direction that policymakers should be going, and all of the attendant actions that need to be taken to get there.
Thank you. Omar.
I was thinking really hard on this one. But I'm gonna just take it back.
Take your time.
No, I think by all these recommendations that we have put together today, Sarah, is patients are going to be the most affected by these recommendations. So if it's any messaging that we are going to develop or provide forward, it needs to be co-created with patients. Patients need to be at the room. We need to make sure that our stories are told in an effective manner, and how vaccines are important to us, they're safe, they're whatever message you put in it, patients need to be at the front and they need to co-create it.
Albert.
I think this has been said already, but without something like ACIP or other kind of central federal bodies kind of leading the way and coordinating things, you end up in social networks what you call a hollow core. There's no one, and so that means that everyone who remains, and I think Kate said this earlier, they need to have a coordinated messaging, coordinated, The scientists need to coordinate with the physician, the various infectious disease societies and groups. If they could coordinate what we know about the science and the evidence and coordinate the messaging, that would really help with confidence among providers, because physicians are often we're not clear on what our leaders are telling us. We don't know what
And
this
your people too,
and
right?
our
Your people
people
too. Yeah.
and then our patients are going to be and someone said this earlier, like if the physician is unclear of the evidence, they're not going to recommend it very strongly. So I think there's a big role for coordination among physician groups that could play a huge role.
And Jason.
This reminds me of what's coming up for the CPAC, where the folks at the end of the alphabet, like myself, have all the good ideas already grabbed by my colleagues. Couldn't agree more. I'll just sort of maybe tie a few threads together in terms of this idea of coordination and trying to think about the idea to try and take away the sense that the vaccine science and policy landscape is hopelessly fragmented, because it's not. So that all of these other entities, the ones we've talked about in the states and municipalities, all these different groups who are working together, thanks to the consortia that were mentioned, and are working on messaging, really do try as best they can to prioritize the clarity in that the science hasn't changed overnight. The evidence hasn't changed overnight. There isn't 27 different ways of thinking about how vaccines are used. There's largely a consensus that remains as it is across all those other bodies. And then there's unfortunately a very different view that we're seeing from the federal government. And to try and sort of in all of their work is to think about all of that harmony and agreement across stakeholders, disciplines, societies, institutions, I think could go a long way to trying to reduce that climate of confusion that I think, I began with today. So, in other words, amen to everything my colleague said.
And I'm going to take moderator's prerogative and reflect a little on how I've been thinking about this question myself, because, we have been doing reviews for a long time, not just on prescription drugs, which is what we're most known for, but health system interventions, diagnostics, devices. And one thing that has always come through is how we communicate what we know and what we don't. And I think that's such a theme that you all touched on so beautifully today about messaging and clarity. But to me, it's also about how you rebuild trust at the end of the day, because is when you tell the truth. And you be very clear about what the evidence says and what the evidence doesn't say. And then you say, and if the evidence doesn't tell us that, we're still going to make this recommendation, and here's why. And I think that to me is the thing that I'm holding my hat on for the discussion and deliberation today, where there might remain uncertainty. It may very well be that the recommendation is everyone 6 months and older should get a COVID vaccine, even though we had votes today where the evidence was maybe not so strong in some subpopulations. And that may entirely be the right thing to do from a public health perspective, but we tell them why. And so that's how I'm thinking about sort of what I would like to carry forward from this meeting to those who are going to have the really challenging and important task of translating that evidence and other priorities into recommendations for this upcoming season. As we close today, it only just occurred to me today, and I will admit, I spent some time in show choir and in musicals in high school, and I won't lie, the round of applause at the end is kind of the best part. And the downside of a virtual meeting is you guys don't get to experience like all the people listening today giving you a robust round of applause for your amazing contributions to this conversation, and especially to Albert, Jason, Omar, and Lee, who spent the whole day with us, although I think I saw Kate and Kimberly were with us viewing as well. You guys are all gems. Thank you so much for spending time with us, offering your perspectives to this terribly important question. I think that this report is just all the much more stronger for having your perspectives. And so please imagine a big audience giving you a round of applause. And with that, it is my pleasure to invite Jason and the entire New England CPAC with guest appearances from the Midwest CPAC back on camera as we go through the final reflections from our New England CPAC after listening to today's meeting. Thank you, everybody.
Thank you. Thank you, Sarah, and for all the policy roundtable participants for a really amazing conversation and discussion. We will just go through our list. We just have a concluding statement from every member of the CPAC. It can be relatively, I think at one point we were saying one sentence, but I should say relatively brief. Let's just say that. And I will start with Professor Conti.
Thank you. Thank you for an absolutely illuminating discussion that was very data-driven and where we really acknowledged both the what we know and what we don't know and what we can do to move forward.
Thank you. Dr. Gold.
First of all, I just want to clap for the people who are still on because now you can see us. That's for the showmanship, Sarah. So I think what I came out from this, these are some of my big points. The public sector really has the obligation to provide vaccines to the uninsured. And so I was concerned about, thinking that some of this would go to the private sector as a responsibility. I think the push has to continue to be to the feds for that. In terms of research, as you have been able to tell from all the questions I've asked, I'm really concerned about the transmission issue. I'm also concerned about how in the report it's given not a lot of discussion. And I'm hoping in the policy piece, some of the things that have arisen in this discussion where we're told that early along, clearly there was effectiveness in aborting transmission, even though that may not be true now. I think that needs to be raised up. And I think part of raising that up is to put the pressure on the federal government to be frightened about what happens if we have a variant that, collapses productivity. Talking to them economically, talking to them about the sort of failures of health in the United States. So anyway, all of this links back to giving a higher profile to transmission, even if there's a lot of uncertainty about it. So those are my ideas. Thank you. And great meeting. Thank you.
Thank you. Dr. Falkeder.
Yeah, thanks so much for having me. There was another great discussion. I was very happy to see that actually it remains cost effective despite the absolutely plummeting rate of hospitalizations. So that's really good news. And it's becoming clear that really the strength of the recommendation when folks will use your excellent work will really depend on a couple of things. One would be obviously the baseline risk and whether they're immune compromised or not and what age group they belong to. And that document will really be super helpful in being able to tailor any type of recommendation to the recipient of those vaccinations in terms of what they can expect, how much reduction in risk of hospitalization or intensive care or even mortality. So super valuable. Thank you so much.
Thank you. Dr. Kim.
First of all, thank you for ICER team for undertaking one of the most important contentious topic in amazing ways. That very thorough, very tough, a lot of heterogeneity. So I really kudos to all the amazing report. And this is remind me, a few years ago, I actually wrote an article titled "Vaccines Are Not Cost Effective. Vaccinations Are." And I think it keep reminding me of like my articles that reinforce that point, that it's pretty clear that there are number of important subgroups that COVID vaccine bring tremendous value. So I think from this ICER's report, wonderful conversations around the policy roundtable can actually bring the COVID vaccine into real world value of the vaccinations. So that's kind of my key takeaway.
Thank you. Don Kreis.
Thank you. As a representative of patients and families, I find myself thinking back to things I did in the spring of 2021. I remember flying to Florida to make sure that my daughter got an early COVID vaccine, and then I myself stood out in the cold and rain of a March in New Hampshire, making sure that I was right at the head of the line when the COVID vaccine was made available to me. This is so important. I love the AARP. So, of course, I was really delighted to hear Lee Purvis of AARP say that her recommendation is that if you want a vaccine and it's safe and effective, you should be able to get one. It's really reassuring to me to see the ICER approach to these questions applied to the question of COVID-19 vaccines. In the world I'd rather live in, it wouldn't really be necessary any more than it would be necessary to have ICER prove that I should floss my teeth. But here we are, and I'm really glad that the rigor of this approach demonstrates that COVID-19 vaccines are a good piece of medicine for almost everybody, if not everybody. So very grateful to have been part of this conversation today. Thank you.
Thank you. Thank you. Dr. Coopers.
I just wanted to say I really appreciated this excellent discussion on a very important issue today. And I echo the previous comments that were stated already today about the value and the cost effectiveness of the vaccines. And I just wanted to also say thank you to all of our experts today for adding in their perspectives. They were very valuable. Thank you.
Thank you. Dr. Mitchell.
So there's this factoid in health tech assessment that goes back a ways. I'm not 100% sure if it is true, but it's that the biggest unicorn in terms of cost effectiveness is pediatric vaccines, and they're one of the few interventions that is not only cost effective but like cost savings. Cost saving. So it is interesting to see that even if we're not in cost saving territory, that even in the context of an exposed and mostly immune population, that we still see this effectiveness, and that at the end of the day, the math still very heavily favors an ounce of prevention.
Professor Ribbit, sir.
Thank you. I feel like a privilege to be able to participate in this. I learned a great deal. I also gained, I think, a new appreciation of how difficult and subtle the job of ICER is. You think back to the COVID vaccine, right? During the original COVID crisis, the impetus was everybody should get vaccinated as many people as possible. And there was a great social value in that. And then the world changed. And the COVID vaccine became very politically coded. The effectiveness of the vaccine shifted, and subpopulations became more important than the general population. And to capture that complexity and that change in a single report is extraordinarily difficult. And when I think about the difficulty of the messaging job that folks like Albert, who are direct primary care delivers, the complexity of communicating and navigating that changing environment, it blows me away. I don't know how you do it. And so thank you for letting me see that and appreciate that.
Thank you, and thank you for your comment. Dr. Ross.
Well, thank you to everyone for a terrific meeting and terrific engagement and comments, and Jason for coming out of retirement to lead the way. That was, with aplomb, as always. At risk, I don't want to repeat all the excellent comments that have been made and many important insights. I will, though, echo what Jason Schwartz said at the top of the policy roundtable, which is like, it really would be terrific to have better evidence in this space because it is so politically charged, because there is such mistrust around these interventions. To me, I look at a lot of the data for particular subpopulations and see near equipoise. And so why are we not running RCTs to determine how beneficial this might be season to season? So I really am sort of, yelling at the clouds. I would like to see better evidence. For some, and for others, that I think would sort of put to rest how clearly this intervention works and are effective for other populations. So thank you again for letting me participate.
you. Professor Vale.
Thanks. This was another really terrific meeting. I really enjoyed, in particular, the insights from the roundtable. And I want to say ditto to all the comments above me because I think they were all really excellent. But I would also just like to add and underscore the discussion around the importance of pharmacists in the role of preventive care and specifically the need for removal of barriers that exclude our participation. So as it relates to COVID vaccine, things like prescription requirements for vaccinating. Thank you.
Thank you. Dr. Wadera. Rishi Wadera. He's off. Yeah, he's off the call. Dr. Winston.
First, thanks for accepting Midwest CEPAC interlocutor. I appreciate the ability to interact with New England CEPAC. It's really difficult to overstate the risk to the public health of the misinformation that we've discussed in some detail or alluded to. So it's really to ICER's credit that we had the opportunity today to deliberate the details of this sober and disciplined report. To whatever extent that this report can contribute to the overall challenge and to move the process forward to affecting the population's health, I just would cheer us all on for our contribution in doing that. So again, thanks a lot and nice job, Jason.
I'll conclude by saying that it's been a privilege to play in this role. I am grateful for extraordinary work by this research team. It really is very difficult to think about the extrapolatability of evidence, the huge numbers of subpopulations. This was a particularly complicated one, and I appreciate the research's team rigor and dispassionate rigor in applying the sort of real kind of evidence-based medicine standards to these data. And I'm reminded multiple times of the day, I think for reasons that were at times wistful, but at times just sad, about things that I had gone through, especially when David was talking about some of his work in 2020. I mean, these are sort of traumatic memories for a lot of us that work in the field. And I just remember and honor the heroism that happened in 2020. It's not something that we talk about a lot anymore, but it's in a lot of our minds, and it'll kind of not go away about kind of what I saw some people do and the risks that they took. And I want to honor that heroism. And then I also would say that it reminds me in a wistful way, in sort of a happier way, of like wonderful people that taught me even 20 years ago when I was a medical student, people like Paul Farmer, about the way that approach people with compassion and humility and a lack of judgment, I think is often really the best way to sort of build trusts between caregivers and communities. And I hope that we can kind of take that spirit forward, because we've got a lot of work to do in terms of rebuilding that. I am honored to be here, and thank you all for your time.
Jason, thank you. Before I close us out, Rishi's internet came back on, and so we're going to give Rishi a moment to give his final reflections. Rishi, go ahead.
Well, it's tough to follow that final word from Jason, but
agreed.
So I'm sorry, Jason, but I just wanted to thank the ICER team, the experts, and Jason also for always doing a wonderful job chairing these sessions. I think the discussion was really nuanced and careful, which I appreciated, particularly when you're talking about average treatment effects at the population level versus heterogeneity, a lot of heterogeneity and uncertainty at the subgroup level. So I just thought the discussion was incredible. And it, like Jason just mentioned, it brought me back to 2020 and being in the hospital and having a sister and a fiance who are on the front lines in New York City. Just amazing how far we've come since then.
Rishi, thank you, Jason, and all of the CEPAC. Thank you. One final slide as we wrap up today, just to let everybody know that we will be posting the recordings of today next week on the ICER website. The final report, which will include a write-up of the voting and the deliberation, as well as the policy roundtable discussion, will be published on or around July 28th. And you can find all of the materials on the COVID-19 section of our website. And with that, it is my pleasure to adjourn today's meeting of the New England CEPAC, and I hope everyone has a great day.
Thank you, Sarah, for doing this, for getting the team to do this.